Jiang, and thanks, Vineet, for giving me the honor to be in this webinar. I wouldn't say I'm a real expert on Urolift. I would just say that it's a service that we just started since last year in Singapore. Let me share the screen. Yeah, so I'm currently a private urologist in practice. So I practice in the Mount Elizabeth hospitals as well as in the Farrer Park Hospital. So I'll just move on. So the BPH treatment when I was still an innocent medical officer was quite straightforward. It's you treat the patient with medications, and then the gold standard of TRP. Those patients either not fit or they can't undergo TRP. They just have to leave the IDC for those in retention. And then if you have a sexual dysfunction, so be it. So that's what my interest to be an andrologist. So the take on BPH treatment today, you can see there's so much things, even for the medications wise, we're even use things like PDE5 inhibitors like tadalafil to treat BPH. And in terms of surgery, other than just the TRP, monopolar versus bipolar, we're even using green light laser and then hormone laser also. And of course, MIS, which is the minimally invasive treatment, currently is something that everybody is quite happy about. It's relatively quite sexy, I'll say. So the ability to ejaculate is something that sexually active men will deem as vital to the sexual experience. So, however, as urologists, we often neglect that in the treatment of BPH because what we want to do is to improve the flow so the patient doesn't go to retention. But we find that actually a lot of men are really upset that they can't ejaculate. So I find that Urolift is actually an answer to this group of patients that we see. So patients who will potentially benefit will be those who want to stop the long-term medications for BPE, as well as patients who can't accept the sexual side effects of the medication or TRP. So during my fellowship in Tulane, I had the honor to be able to perform the Urolift then in 2014. That was when it started in the US. So when I did the first few Urolift tests, I was quite sure that I want to bring this modality of treatment to Singapore and the region. But it took 5 years before actually Urolift arrived at our shores. So we started the first Urolift on the 16th of October last year. And I was honored to have Professor Henry Wu, who was one of the pioneers of this Urolift, to be my proctor for the first cases that I put up. So basically, Urolift or PUL, prostatic urethral lift, involves the transurethral placement of small permanent implants to retract the lateral lobes of the prostate so as to reduce the obstruction. Basically, there's no destruction of tissue. You're just pushing aside the lobes that were obstructing, and that's what Urolift is all about. So we all know the potential sexual dysfunction associated with the medications used to treat treat BPH. Yeah, and this is a nice flow chart by my colleagues from Tulane Hospital. So they basically showed that there's the proposed mechanisms whereby treatment of BPH can cause sexual dysfunction. So I'll move on from here. So looking at this table, the thing that really shows is that Urolift or prostatic urethral lift does not have any risk of post-operative sexual dysfunction especially in terms of ejaculatory function. Same thing. I'll just share some of the studies that was used. So the BPH6 study basically shows that Urolift is able to preserve ejaculatory function compared to the gold standard of TRP. This is another study which showed that there's symptom response and flow rate improvement as well as sexual function. So you see the main thing that's popping out now for Urolift basically is sexual function. And then there's the LIFT study, LIFT study, which shows that the results are actually durable up to 5 years. And the sexual function again is stable. Of course, I did not highlight there, but you can read there. There is a surgical retreatment, about 13.6%. So the patient needs to understand that this may be interim treatment because at the end of the day, the prostate continues to grow. So I'm not saying that Urolift will definitely replace the gold standard of TRP, where we actually resect the prostate, or even things like enucleation of prostate, where the whole adenoma is removed. So we have to be very honest with the patient what we are trying to achieve here. So if you look at this real-world evidence study, it shows a drop of 8 points in IPSS. So what do the guidelines say? So the EAU guidelines have already included the PU lift or Urolift into part of the guidelines. You can see here, really they are more conservative, looking at patients with smaller glands, 30 to 80 grams, or those patients that cannot undergo anesthesia. Because Urolift can be done under IV sedation. In some cases where the procedure is even more advanced, they actually do it under local anesthesia. So in words, basically you can offer prostatic urethral lift to patients with LUTS. The important thing is they want to preserve their ejaculatory function. So that should be the starting point. And of course, smaller prostates with no median lobes these are the best patients that you offer. What do the Americans say? In the EAU guidelines, you can see over here, PUL. Basically for them, they are looking at smaller prostates or average size prostate. Basically less than 80 grams is what they'll recommend. And of course, they will frown upon the fact that if you want to do this procedure on patients with median lobe. That's when it first started. But now more and more patient, urologists are actually using it for patients even with median lobes. Same thing. The key feature is if the patient is really finds that the sexual function is really important during the treatment of BPH, that we should talk about Urolift. Nice guidelines, also has some recommendation. So basically, this is what the implant looks like. So on the left, you can see the Urolift permanent implant, which is a suture, and then there are two tabs to it. The 19-hour capsular tab, which will be fired through the prostate, and then you land on the prostatic capsule. And on the inside, you have the stainless steel urethral endpiece. So you can imagine it's like you use your curtain ties to tie a curtain, you push it aside to tie it together. Basically, that's what you're doing. So these implants are delivered by this delivery device. At this point in time, one delivery device fires only one implant. So you can imagine you end up with a lot of trash after that. Okay, so we do it in an exaggerated lithotomy position under IV sedation. That's how I do it, using a 0 degree 20 French cystoscope. And the implants are placed at 2 o'clock and 10 o'clock. And the important thing is to make sure that you place the implant about 1.5 to 2 cm from the bladder neck, because the chance of you causing stone formation by leaving the tap too close to the bladder neck is an issue. And of course, patient will have more symptoms of urgency. And then most distally will be similar like how we do TRP. We take the varium montanum as our most distal landmark. So this is another schematic showing how the Urolift will look like. So basically, when you introduce the device, you fire it out. The capsular tab will then turn, and then you cut the suture and apply the urethral end piece, and then this is what you have. Yeah, so this is what you're trying to achieve at the end of the day. So it's unlike TRP, where when I was trained, I was told that after resection, you're supposed to look as if Jennifer Lopez had sat on the beach and it formed the two nice curvatures here where you can see all the way into the bladder. So in post-procedure, like I mentioned, anterior channel is what you want to create here, which is a little bit different from what we're doing for TRP. The lateral lobes that look at it should be pulled apart. However, do not expect to look like post-TRP. No, you end up firing lots of implants in there. The patient will have to pay through his nose, and I don't think it's fair to the patient. So the challenges with Urolift, I think the first thing is the patient's expectations. So if the patient comes to you asking you about this procedure, the important thing is if they feel that the ejaculatory function is really important, then we will start the conversation. Let's say if he's a very old person, ejaculation is not an issue, it's not even sexually active, and his prostate is really big, I think it will not be fair to do Urolift for this patient, unless, for example, if they're really unfit for surgery, we can always discuss that way. But if you talk about your typical patient, they can undergo surgery, no risk, and all that. The expectations of the sexual function should be the most important thing. The size of the prostate, a lot of times we think that the bigger the prostate will be difficult, but for Urolift, even if the prostate is really small, it becomes an issue because I'll show you later. And the most important thing is the configuration of the prostate. Those without median lobes are still the easiest to do, and the outcome is usually better. They have come up with other maneuvers to actually deal with the median lobe. But I have not had the experience of doing those patients with big median lobes because I tend to be more conservative. And I feel that this treatment should be reserved for patients who want to keep ejaculatory function. So a lot of these patients that see me, they're slightly younger. They're not keen for long-term medication. So in that way, the way I select the patients also end up with a certain type. Okay, so I'll just show a few videos here. So first patient is a 51-year-old male with very severe symptoms. You can see over here. So he was given the alpha blockers and combination therapy subsequently by another urologist. So he was very upset about his retrograde ejaculation, and there was no improvement of flow. So you can see over here, the urol flow, lots of straining, hardly any urine coming out, but he wasn't in much of retention, although it was a low voided volume. He's unable to actually hold his bladder too long. He has quite a lot of urgency symptoms. So a transrectal ultrasound was performed. His prostate volume is about 30 grams, and there's no IPP. Let's see over here. Vesical cystoscopy is recommended so that you can have an idea of how many implants that you will need to put for this patient. So in terms of financial counseling, the patient would it be easier. So you can make a joint decision together with the patient. Okay, to show the video now. Okay, this is what the device looks like, Urolift. So I'm in the bladder, I'm pulling back, you can see this bladder neck. Like I mentioned, it should come out about 1.5 cm to 2 cm from the bladder neck. Let me go distally, so that you will not fire the clip into the bladder because you're worried about it causing stone formation, like I mentioned, as well as really terrible urgency symptoms. So the recommended positions will be 10 and 12. So you can see I fired it. You see the blue line? The blue line shows that the device has fired out and the prostatic clip is already deployed. All right, let's put it on the other side. So you try to push the lateral lobes and try to smooth it out as much as you can and deploy at the 2 and 10 o'clock. So this is after firing. Subsequently, if you pull back, you actually see a white line. Yeah, this will be the idea of when you can actually cut the suture to deploy the urethral handpiece. Right. This was one of my first few cases, so I was really concerned about this bleeding. But trust me, the patient went back without a catheter. There was no glossy material. So I was considering whether to put another implant, because you can actually see there's quite an adequate anterior channel. Right. So I was deciding. So I decided to put another one on the patient's right to try to move away this lobe that was a little bit obstructive. Fast forward. Same thing. So this is the white line you're talking about. Yeah, you see the white line, you move forward and you fire off. So at the end of the day, this is what you see. Obstructing lateral lobes are pulled apart. We have anterior channel. So this patient required 3 implants. So it's show you again his uroflow. After the procedure, about 1 month's time, his uroflow has actually improved. Although it's not the best, where you expect of TRP, where you expect the patient to be shooting at 25 mils per second. But to him, he could stop his medications. His symptoms actually dropped from 31 down to 9. And he can actually hold his bladder out more about 100 mils and without much of residual urine. So it's quite happy that, yeah. So when the couple came to see me, the wife was also smiling. So I think he managed to achieve his sexual function. 51-year-old, same thing, patient on dutasteride and tamoxifen by another urologist for 9 months, and came to see me because of the badly affected sex drive due to the dutasteride. So his IPSS is, I'm saying, moderate, not too bad. This is uroflow. He had to double void. So I did the transrectal ultrasound similarly. He had an IPP of about 96 millimeters. So this one was a little bit hesitant whether to proceed, but the patient was really keen. So this was cystoscopy that was done by the urologist that was referred to me. You can see over here. So we have a look. Okay, same thing. So I went in. So you can see the medial lobe picking up here. All right. So the key is to see whether there's any space where you can actually tag the medial lobe if you really need to, for some of the more improved maneuvers. But I think as the first few cases, not a good idea to start with a median lobe because you have to be very comfortable with how to deploy the implants first before doing this. So I think it's always easier to deploy on the lateral lobes. And once you're more comfortable, then you can consider doing the median lobe. All right. So I'll fast forward this a little. So basically, I fired a total of 5. So at the end, you find the lateral lobes are moved apart, and the median lobe tends to be a little bit lower because it's stretched to the side. We find that when we do that, sometimes the median lobe is actually pulled into the prostatic urethra, and that does help to increase the anterior channel that you see. So I place 3 on the left side and 2 on the patient's right side. So the outcome is something like this. I was a bit worried because the median lobe was still a little bit there, but the proctor that was with me felt that it's a very good channel. So we took the leap of faith, spoke to the patient. The patient was actually okay. This is the pre-op. So post-operatively, at 1 month's time, his maximum flow rate was 10.5. He voided 300, and his RU was actually 60. He was actually quite happy. Still having a little many symptoms of irritation, but the flow-wise is quite satisfied. And the best thing is he stopped his medication, and he's able to function in the bedroom. All right. So there's another group of patients that I see. Let's say, for example, you have a patient who has been on alpha blockers for a while. They're quite happy with the flow, but he feels that he's still young. He wants to really ejaculate. He doesn't want to take the medication. That's also something that you can offer to the patient. So you can see this patient's uroflow relatively okay. But his IPSS not the best, but the PVR is only 59. I did an ultrasound of the prostate, same thing, 31 grams. I tend to get all the 30 grams, I don't know. So there's no intravesical protrusion of prostate here. During the scope, all you see is maybe a little bit of enlarged lateral lobes. So you can see over here, that's the lateral lobes. Looking a bit meaty on each side. No real high bladder neck, no median lobe at all. So this is always the best type of TRP that your resident want to do. So yeah, that's the problem. You do Urolift for residents, no more TRP to do. So anyway, so we're saying push it in, take a look, pull it back. And then this is a relatively straightforward one because you can see the lateral lobes. You just move it to the side and then you fire it out. So same thing, about 1.5 centimeters or 2 centimeters from the neck that I mentioned. And then you push the prostate side. Yeah. Fire, same thing, you will see the blue. Then you move forward and you see a white line. That's where you deploy the urethral end piece. That's where you cut the suture. Repeating on the other side. You can see a nice anterior channel over here. But I wasn't too satisfied with the left side that was bulging down a little bit. So again, I placed it. Yeah. So at the end, usually what you can see after you fire, you can push forward, and if let's say there's no resistance, and even when you turn off the flow, the channel is actually quite big. It shows the anterior channel has been created. Always take a nice picture to show the patient what you've done. 3 implants. So this is a pre-op uroflow at 1 month. This uroflow 25, he voided 467, RU was 0. So the main thing for him was he wanted to stop his medication. So this, even after stopping his alpha blocker, he could actually pee properly. He did not find any worsening without the medication. So same thing, his main issue was still about ejaculation, which he no longer had increased volume of ejaculate. The last case that I show will be a younger patient with high bladder neck. This is relatively quite challenging. So it was complaint of obstructive symptoms. This was done by my colleague. I wasn't given the IPSS, unfortunately. So this was a uroflow, a bit of straining. It was a transabdominal ultrasound. I usually do transrectal ultrasound before I do Urolift for a better estimation of size as well as looking at the IPP. But based on this transabdominal ultrasound, it was estimated about 40 grams with no IPP. So that's what the cystoscope looks like.
On.
So you can see high bladder neck, lateral lobes are minimally blocking also. So we discussed with the patient, but the patient is not keen to take alpha blockers because he says that will definitely affect his sex life. He's only 38 years old. So in the scope, you can see the bladder neck is really high, not much of a lateral lobes. So before the procedure, we actually told the patient that he must understand that when because laterals are not very big, when you find always a problem, and his symptoms of irritation may not improve. At best, we can try to get a good channel for him so he can stop his alpha blockers. So same thing, blue showing that the implant is already fired out, and then the white line to show that now the capsular tab is already engaged. You can then deploy the urethral handpiece. Similarly on the other side. So after putting, you find that it actually drags the bladder neck comes down a little bit. Sometimes the bladder neck is really high. When you fire the implants, you end up with a very, very tight bladder neck. So in those cases, you know the outcome is not going to be good. So have to choose wise for these patients and really counsel them well so that you not get into trouble with these guys. So I place 3 implants also. So at the end of the 3 implants, you can see from here, manage to lower down the bladder neck a little bit. Yeah. So Uroflow before surgery. And I was quite surprised to actually see that you can actually do quite a relatively well, a nice shape Uroflow that we expect in a younger patient. So, and he wasn't in retention. His IPSS score is still quite high, very, very irritative symptoms. Initially, post-op, he had very bad urgency, which actually got better with time. After about a month or so, he's perfectly okay. So currently, he has stopped his medication and is happy with the flow. So I submitted my outcomes in terms of IPSS. So I want to thank Teleflex that they actually prepared this this chart for me to show the graph to show that the outcomes are similar to the 1-year live study that they usually for patients. So just now, as I mentioned, the median lobe is a really no-no. So those urologists who are actually doing Urolift quite a lot, they went on to do this MedLift study where they actually deal with the obstructive median lobe, or they call the OML. Okay. So they compared doing just Urolift alone versus Urolift with maneuver to move away the obstructive median lobe. They find that the results are relatively good. So at the end of the day, for Urolift, I find that the patient's need to be able to ejaculate is the key in determining whether he should go for Urolift or not. So as urologists, it would then be up to us to counsel the patient if he is feasible for Urolift. As you know, surgery is not just a science, it's also an art. So the way we build our scalpel, in this case, the way you actually place the implant will determine whether the patient will benefit the most from the procedure or not. So I reiterate again that Urolift is not here to completely replace TURP. It's basically look at this group of patients who are not keen to take medications. They're probably the prostate is way too small for TURP, and the most important thing is still the need for them to inject it.
Right? Okay, thank you, Ronnie. So as moderator, I'm going to be collating the questions, and I do have quite a few already. Just like to take a brief mention and welcome. I think about 350 people watching this webinar from about 15 different countries, including Africa, Mongolia, and the Middle East. So welcome everybody. So questions coming fast and furious. First question I think everybody's asking is learning curve. What's your learning curve like for Urology?
Okay. Yeah, so for the Teleflex company, they do have this training program for urologists who are keen to start Urolift. So their recommendation is usually about 15 cases. I find that in the first 5 cases, you actually will find you get comfortable with how much you can actually torque the device. Because what you're concerned about is always firing the device when it goes all the way out. because you're worried about hitting the bone. So one of the recommendations is to put the patient in exaggerated deformity position, let the buttock hang a little bit from the bed. And yeah, that's something they find that actually helps.
Okay, so then the other question people are asking is basically the number of tabs. We know the tabs are expensive. So how do you predict? Because it seems as if you kind of judge it as you go along.
Yeah, so of course we will do the flexible cystoscope. During the scope itself, roughly you have a judge of how long the prostate is. Also from your transrectal ultrasound, when you measure the prostate. Most men will take up to about 4 to 6 implants. Maybe my personal view is if you need to fire more than 6 implants, probably you'll be better off doing a TURP because there's so much prostate to move away. Yeah.
Right. Okay, so would you say this is essentially a bit operator dependent? Expertise counts, experience counts.
Yes.
Because you say 1.5 cm from the bladder neck, but you actually don't measure it. It's kind of an estimate,
Yes.
right? So would you say this is more a bit of experience in how you position it specifically?
Yeah. So what I recommend is actually starting cases not on those with median lobes, start with those with lateral lobes only, smaller prostate. So slowly, as you find that you're more comfortable with actually deploying the implants, then to be fairer to the patient. Because if you just list a 90 grammer with IPP, grade 3 IPP, I don't think it's fair to the patient.
Right. Big question about the tabs itself. Is the tab itself lithogenic if it was still in the urethra? Has it been shown?
So far, they have not shown that the implants that's placed in the urethra actually causes stone formation, because the understanding is that because you find that when you place the urethral implant, the mucosa can still grow over it because the implant it's actually pushing under the mucosa.
Right.
So they've done studies and find that as long as you don't deploy into the bladder neck, into the bladder, the chance of reformation is very low.
Okay. Would you do this in a previous TURP patient?
I wouldn't. Yeah, because I'm a bit concerned about the fact that because post TRP, there's a lot of scarring. I don't think there's so much to actually pull the tissue apart.
But conversely, if the patient had a TURP after Urolift, what's the consideration for the fact that there's a foreign body there when you are resecting?
Yeah. So during the resection, because the suture will be cut by the diatemy anyway. So the important thing is to wash out the urethral end plate if you see it. Whatever is in the capsular end, you're not worried.
Okay. So in what situations would you catheterize the patient? Any situation?
Okay. For catheterization will be, for example, after firing, you find that there's quite a bit of hematuria that you're uncomfortable with. Usually I put a catheter in. But if let's say it's not too bad, I think it's fine. For those urologists who actually use it for the median lobes, they will catheterize the patient because they just put it in, keep it overnight before they take it out. They're more comfortable because of this manipulation of the median lobe.
Is there reports of rectal injury? Because if you're especially going median lobe?
Okay, so yes, we did ask those specialists who are actually doing the median lobes. They feel that when you do the median lobe, what you do is actually you try to tag the median lobe to one of the lateral lobes. And then because you're actually pushing it towards the bladder neck and you're firing it backwards towards the urethral, the prostatic urethra, they find that the length of the implant should not enter the rectum. So far, there's no reports of rectal.
No reports. So, okay, we're all waiting, hopefully not to hear about one case. Yes. One last question would be, what is the oldest patient that you think would be suitable, or is there an age limit for this?
I don't think there's an age limit. So like I mentioned, the important thing is basically the patient's expectations. Usually when the patient comes in and asks me about Urolift, I'll tell them what's their main concern. If their main concern is ejaculation and the prostate is not that big, then I will do it.
Okay, sorry, I missed out one question. Infection rate, is there an infection issue that you're concerned about?
So far, no. It's relatively safe. Yeah.
Right. Okay. So I think that's about all I can see for the questions. So thank you, Ronnie.